welcome to the first episode of Wound Care Legends of India, where we delve deep into the experiences, insights, and stories of the pioneers who have shaped our wound care in India. I'm your host, Dr. Sanjay Sharma, and today we have a very special guest who is a true legend in the field of plastic and diabetic foot surgeries, Dr. Sanjay Vaidya. We have seen in our practice the mupirocin being extensively used. Every physician, if there is a chronic ulcer, they will say use the mupirocin. What are your thoughts on that?
No, I would say at least I don't use mupirocin at all. Nowhere in the spectrum of no.
Okay, interesting. And also from the silver dressings, you just mentioned silver dressings. There is also a thing that it cannot be used more than 28 days or 1 month or kind of a thing. What are your thoughts on those?
Well, it can be used at times for a longer period of time, but if you really ask me, we are using a good silver dressing, by and large within 4 weeks time the infection will get under control.
Okay. So we do not need to use it beyond it. And post the infection control, I know there are also dressings which will help in the MMP regulation and also in terms of the VGF growth and other things. When is it that can be introduced?
Yes, once you have clean, healthy granulating wound, again, there should not be any slough, no infection, there should be no PVD, so there should be adequate circulation. Then you start using, or maybe sometimes a mild ischemic wound, certain dressings can be used, but then you have to use this dressing judiciously, because what happens is if it is used in a wrongly indicated case, the dressing will get a bad name, and then that is how they lose the popularity.
So is there any do's and don'ts in terms of what can be used in a diabetic foot ulcer versus any other chronic ulcers?
No difference per se, because any chronic wound ultimately is going to be similar, but as I said, in diabetic patients, neuropathy adds to the complexity of the problem. So also many times there is a vascularity challenges, PVD, so all that we have to keep in mind, and you have to treat the root cause. Unless you treat the root cause, we cannot superficially be treating the wound and expecting a good result. At times you may have a very chronic non-healing ulcer which turns out to be a vasculitis, so you have to obviously involve the rheumatologist and start with steroids or some other immunosuppression before you start seeing a good result. Otherwise, I have seen patients who have had some even skin grafting done 2 or 3 times outside which have failed, and they come to us and we do a simple biopsy and turns out to be vasculitis. And even sometimes, to our surprise, chronic wounds have turned out to be basal cell carcinomas, squamous cell carcinomas, so you have to tackle them accordingly.
So it's linking now. So what was the most challenging case that you have seen in your career? Probably 3. I wouldn't say put 1. Probably 3 challenging cases that you have seen where you had to use all your arms in your to tackle that wound.
Well, there are many which come to my mind, but I can remember a couple of cases which were done during COVID time, because it was more challenging to treat those patients during COVID times. Now, I had one of my patients who was my regular patient, a chronic smoker, about 67-year-old male, diabetic, obviously with severe peripheral vascular disease. He developed a ischemic ulcer on the great toe. He went to a local vascular surgeon where he did a angioplasty and did a great toe amputation. Now, this gentleman, because of COVID times, as I told you, actually it was a challenge to probably travel distances. But then after 3 months he came to me. When I saw there was a spreading necrosis, the moment I saw that, I realized, oh, probably the fascias got blocked, because obviously he's a smoker, so it's going to bad disease. So got again repeat angioplasty done and did a midfoot amputation. Again the bones were looking very necrotic. So I told him, look, this is not going to work, we have to go for a below knee amputation looks like. But he said, which I am very reluctant to do anyway, but the patient as well as daughter, they were absolutely against it. So he said, come what may, you try your best but try to save. So what I started doing was, I initially started putting on negative pressure wound therapy, along with that once a week, till we came to a stage where gradually got a stage where there were exposed bones, but otherwise the whole thing was covered with a granulation. And then I put one of the extracellular matrices on top, then again put a NPWT, subsequently put a skin graft, and today that fellow is walking around
Awesome.
with a proper customized footwear.
Awesome.
Also, I remember, in fact, another very challenging case, other end of the spectrum. This fellow was a smoker. Now, here comes a young lady coming from out of Mumbai, 28 years old, diabetic, with sudden onset of gangrene of the toes and heel. Got her admitted again during COVID times. She was married just before the episode, and I asked the intervention radiologist to do angiography and, if possible, angioplasty. He said plasty is not possible. So we involved a vascular surgeon. He did a FEMPOP bypass, but there was no great distal runoff. So he also was of the opinion, considering COVID times, I think we should go for a quick below knee amputation. To which the husband and wife flatly refused. They said, "Come what may, we have to save this limb. We just got married few months back." So again, with skepticism, I went ahead with a 4-foot amputation, did a thorough debridement over the heel, where I got a complete necrotic periosteum sitting there on the calcaneum. Even the 4-foot amputation site was not looking very promising, but again, perseverance, NPWT, in a week, continued with that till I came to a point where I could put again another matrix there on the calcaneum to give a little extra cushioning, then put a skin graft, prepared a customized footwear in my clinic, and she went back home very happily.
Awesome.
So that's very gratifying.
Absolutely. When people say that you cannot walk and he'll be able to walk in his own hands. So whatever said and done, in spite of you giving a prosthesis or anything, we know the statistics.
Yes.
70% of the people have a 5-year mortality rate, and having their own limb and walking is absolutely gratifying. So coming to the other side of it, I have heard that the Ganesh Chaturthi is coming by, and also you have other interests apart from doing the plastic surgery and saving limbs. So can I know more about your intricate interests other than plastic surgery and saving limbs?
Oh. Well, yes, I always had a spiritual inclination right from my childhood days, and I'm indebted to my guru, Mr. S.K. Devdar, who was my spiritual guide and guru, who taught me all these different mantras and pujas which can be performed. And in fact, for last many years, for Ganesha Sthapana, I have been doing that, the Paurohitya, myself, and our legacy goes back a long way. In fact, in our Vaidya family, we had an idol from a particular sculptor right from 1910. So this is almost now 115th year.
Wow.
We are getting exactly similar idol coming from the same sculptor, 3rd generation. We are 5th generations. And that's something where the whole family comes together and we celebrate that Ganesh Utsav.
And you have a large family, and Maharashtra is known for the Ganesha festival. So can you just give a glimpse of how the festival is celebrated in your family?
Oh, first day of the festival, actually all of us gather together. It's not only our close first cousins or something, different second cousin, third cousin, all the family, actually all of us gather together. Maybe about at least 70 to 80 people coming from, not only from Mumbai, Thane, Pune, other regions. At times even those who are staying abroad, they try to make it so that they can be part of
So it's a 10-day long...
5 days. 5 days.
Okay.
5-day festival.
Okay.
And then we have a long aartis, as we call it, especially a day prior to immersion. We would have a competition of singing aartis for at least 2.5-3 hours.
Oh wow. And the immersion is done
is on the 5th day.
On the 5th
and
day.
another thing, of course, we have a clay idol. It's never a plaster of Paris. It's a clay idol which is
since 1910.
Yes, it's eco-friendly.
Awesome. Also, I was just talking to, I was in Manipal yesterday, and I was talking to one of the anatomists there, and I heard that in the present MBBS curriculum, the foot dissection has been given up. There is no foot dissection at all in the curriculum.
Oh.
So they have the cadavers. The foot has not been dissected at all.
Oh.
And I was surprised by it that the need of the hour is for the MBBS students to learn about the foot. and here we have a curriculum from the NMC where it has been taken off of the foot dissection. So that's where I'm trying to come to the education part of it.
Right.
What do you see is missing in today's education from the undergraduate level to postgraduate level, and what needs to be brought in to these students?
Unfortunately, diabetic foot has never got any importance in the curriculum. It may come only as a short note, if at all. So either undergraduate or even postgraduate curriculum, they hardly pay any attention there. But when they come into actual practice, they realize that come what may, whether they like it or not, they end up treating diabetic foot patients. So I think need of the hour is education, education, education. And all of us who are into this field, I think it's our duty as doctors to our younger generation that we must keep on teaching them. If medical colleges are not teaching, I think it's our duty to teach them, train them, and get them well versed with the field of diabetic foot, right starting from anatomy. That's why, in fact, in upcoming diabetic foot conference,
there.
So I'm the organizing chairman. In fact, made it a point where we have arranged a pre-conference hands-on cadaver workshop, wherein it's just gone full in no time, because people are hungry to learn, but unfortunately they don't have any avenues where they can reach. And now are getting faculty coming right from US, UK, and our own eminent Indian faculty who are going to teach them. Again, different branches, as you rightly said, general surgeons, orthopedic surgeons, plastic surgeons, all of them are coming together to teach these people. So this is very important. I think this hands-on, of course, is a fantastic idea. Apart from that, conducting conferences or CMEs on a regular basis is a need of the hour. And education, again, starting, if you really ask me, educating the patients and relative is one area where we have to focus as doctors. Then coming to a physicians or MBBS cadre, who would be the primary contact for patient of diabetic foot. So they have to be trained and they have to pick up the early signs of dangers, and when they have to refer. Early referral is something which we have to teach them, what they can treat, what they cannot treat, how offloading is important, all that we have to teach them. Then coming to a surgical level, of course, we have to teach them about different surgical techniques, how best they can do, how they should do a radical debridement, what are the do's and don'ts. All that, I think, as few of us who are experienced in this field, I think it's our duty, and I think we should do that.
Also, in terms of the education, podiatry today probably might be synonymous with diabetic foot in India, but it still hasn't got the NMC recognition.
Yes.
We do not have a post graduation or a super speciality or anything like that, where the doctors are trained in the medical colleges.
Yes.
Whatever we have been training is from the societies, or individual interest and other things. What efforts are required? And probably DFSI would already would have been doing it. What is being done and what efforts would be required to get this education in podiatry or education in diabetic foot being recognized, and people can actually see that, okay, I'm doing a super specialization or specialization in this.
See, DFSI has always been in the forefront while creating awareness and teaching. So in fact, at various hospitals we are conducting regular 1-year fellowship program in Mumbai, Coimbatore, Chennai and other places, where there is a huge load of diabetic foot patients, and then we have senior colleagues who are teaching them. So after 1 year they really come out well trained in the field of diabetic foot. But apart from this, we are also trying to contact NMC whether diabetic foot itself can become a DNB course. That is something which as a society we are trying to implement. If we can convince the NMC that we can get a DNB recognition for diabetic foot surgery, that will be a great super speciality, and that will be a great boon to
Absolutely, we'll be looking forward to it, and probably a lot of young surgeons would be looking forward to start there. So if there was an opportunity for you to go back in your life, and probably when you are in your late 20s kind of a thing, would you want to change anything in your life, or
No, never. because whenever I got a turning point, I think I took the right direction.
Awesome. And so how would the younger surgeons take this decision so that they don't regret looking forward? Would you have any advice to the younger surgeons?
Diabetic foot surgery is a need of the hour. If they can learn it properly, take it forward, it's a very gratifying branch, and I think this is something they should do, because if you really look at the practical aspect, vis-a-vis a laparoscopic surgery or going for a cardiac surgery, it is very difficult to set practice. But here we have millions of patients, and what we are lacking is, in fact, the number of doctors are much less. So in fact, it's a good opportunity, great opportunity for youngsters to set up their practice very quickly in short span of time. They can get attachment to various tertiary care hospitals where they can work and save lives and save limbs of the patients.
Awesome. And also, what would be your philosophy or mantra, which you would want to give it to the younger surgeons or anyone who is younger? Like you would have believed in something which you follow as a principle or as a philosophy.
Well, always whatever you are doing, do with sincerity, do with integrity, and as you said, do no harm to the patient. So whenever you are treating the patient, see to it that if you are not given a desired result, at least don't do any harm to the patient.
Is there any last message or anything that you would want to share which I might have missed out today?
Well, we have an ancient Sanskrit saying, "Charati charto bhagha." That means the one who walks, his fortune marches ahead. So we want all our diabetic foot patients in India to keep on walking so that they are also fortunate to, and we should try to be part of it to save their limbs, save their lives. And
thank you very much, Dr. Sanjay Vaidya. This has been an incredibly insightful conversation that we have had on the first episode of Wound Care Legends of India. Thank you very much.
Thank you.